So just to make it easy for what is asked in the questions in the exam, as well as what you can do on your day-to-day practice, some basic things related to quality, patient safety, accreditation, and clinical audit. Most of the hospitals, we all are knowing that they are JCI, NABH accredited, but one of the hesitancy that we see is from the physician side because we think it's a burden and we are always not so proactive for it compared to what we do in our day-to-day work. But certain points that I will highlight will make you aware of why we should be equally active, not only with the clinical care, but also on the quality and patient safety aspects, which is the most important part of the patient care. Because whatever care you take, but if the quality is not good, if the safety factors are not taken into consideration, if it is not done in a standardized way, and if you are not checking it, it's not going to help you anywhere. It's just going to be like, you have achieved a JCI, you have achieved something, but you are not doing what is required for the patient care. So, objective is to understand the key aspects of ICU quality, patient safety, accreditation, and clinical audits. And as I told you, why it matters is the ICU patients we all need to know are critically ill. They require strict protocols, which are very, very important because one thing here and there can matter a lot for the patient. It can be in any form. It can be either in a communication, it can be either in administration of a medication, it may be in ordering of a clinical order that is done. It is multiple aspects, and communication is one of the keys which we all know is a big gap in our healthcare setting, especially in the ICU, because multiple people come in, multiple referrals happen, multiple teams are there. We have a lot of teams involved, not only which is with our care, which is only with the referrals or with the nurses, it is also the dietitians, the physiotherapists, the technicians. So multiple people are involved over here, and there it matters on how you follow the processes to make it very streamlined. Principles of quality in general, you all need to know it's just a basic thing. If somebody asks you what is quality, quality is about managing certain aspects in a hospital. It starts with customer focus. So our customer is, we have internal customers and external customers. So internal customers are all the people who are coming in the hospital, all the people who are actually working in different departments, maybe a biomedical department, maybe our F&B department, maybe our technicians. So multiple people. So they are the customer focus, and external are the patients whom we receive in the hospital. They become one of the most important customers for us because they are the people who are coming to take, some quality of service which they need in the hospital. Leadership starts, it's not only about the leadership, which is either a CEO or a medical director. It involves even leadership at certain levels from the start of our junior resident to going up to the leadership level, because the escalation of things goes up that way. So we need to equally give importance to each step of the leadership. And also it's not only about one department like a ICU department, it is of multiple departments which are there. Then comes people engagement, which I already told you. Engagement is about how we actually work with each other, how we understand each other, how we are engaging the people. So if somebody is coming and trying to treat your patient, somebody is giving an opinion, or you need to talk to someone, and also people engagement involves involving the families of the patient. So it involves families, it involves the consultants, it involves the nurses, everyone who is treating the patient. Process approach. For anything, we need to have a process. Quality is all about process. If you have a strong process, and if that process is followed by everyone, then everyone will follow the process and the patient will recover well from that illness with what the patient has come. When I have to give you a process, I think in anesthesia, you all have learned that for an intubation, you try to follow the steps which are there. You try to go and check everything. It starts from assessing the patient. It starts from taking the history. It starts from the preparation up to the end of confirmation that the endotracheal tube is in place. So that is a process. So this is one process which I am saying, but there are multiple processes which are there in critical care that we all need to understand. From the processes comes improvement. Improvement is what? That if there is something which is not followed, why it was not followed. what were the problems that they were facing, what were the issues that they had, so what we can do to improve it. Then comes evidence-based decision making, which I'm going to tell in my further slides. For anything, we need to have a evidence on what is right, what is wrong, what is the targets that we need to have. So all these things can be only done provided there is a evidence. And in critical care, we have a lot of evidence-based decision making that we need to follow in our ICUs. And lastly, it's the relationship management. The relationship is not only about between the patient and family members, it's also with our colleagues, it's also with our mentors, it's also with our entire team with whom we are treating. It also involves the PCA, PTA, or the attendants who are looking after the patient. So I hope this slide is clear about the principles of quality. I've tried to shorten it and make it easier for you all to understand. And this is what you need to remember in your day-to-day basis. Okay. Then comes the ICU quality. In ICU, key components come into clinical excellence, process efficiency, patient-centered care, and performance metrics. When it is clinical excellence, it is all about following the protocols in an evidence-based manner. Okay. Now, this evidence-based protocols, if I have to tell you, it is simple. ACLS guidelines which are there. If you need to know how you need to treat a patient with a ventricular fibrillation or a patient with a bradycardia or a patient with a flatline protocol that has to be done for a asystole. This is all which has been taught, and this is what it is. One is that you use the evidence base, and secondly, that you are actually training your team who knows on what are these protocols that need to be followed. It is even in ICU, one of the things which is the most sensitive is about medication management, and that includes high risk medications like potassium, heparin, and narcotics that we use in our ICU. Okay, so this is all about the evidence based protocols. Process efficiency, timely interventions, and multidisciplinary care. So, what are the monitoring standards that have been to put up? How you are going to go and intervene over there, and what are you going to do for the benefit of the patient? This involves entire team. It cannot be only one person. So, this is something which we all need to follow. Patient-centered care, it is all related to communication, empathy, dignity, and giving comfort, because it is also one of the areas ICU is where most of the patients are critical and families are always and stressed, always having issues, which is it's not only involving about the care or about how they are feeling bad that they have not reached on time to the hospital or delay in the care that has been happened, but they are also more worried about the finances part. So this is something where we all need to be really, really very, very, do a care with a good empathy. And performance metrics is all about trying to check how we are doing, how whether we are within the standards. And unless we check our performance, we will not know where we are. Simple performances that you need to remember are like mortality, SMR that we calculate, infections, which I told that day also, and again I will show you today also in our dashboard, and typical length of stay. So these are certain things which are the key components of the ICU quality. If you remember in these 4 ways, it's very easy to remember. So patient safety in ICU. Common safety risks, I already told you, medication errors. Medication, because we keep on changing medications. Patients are on vasopressor support. There is a lot of things which are related to patients who are on vasopressors. The syringe pump, whether it is functioning, whether the alarms were attended, whether the connections were done properly. Most of the times, if you might see, there may be a hypotension and you go and check everything, but if you have not checked whether the connection was done properly, the patient will not recover, because whatever you do, everything will go in vain. You will notice after a particular point of time that the bed sheet was wet and all the medication had gone in the bed sheet rather than going through the line that the medication was supposed to be connected. So medication errors is something which we need to understand. Infections. Yes, infections again in ICU, most of the patients are having multiple lines and tubes. They come with sicknesses. There might be multiple reasons for the sicknesses. There are multiple things like patients who have to follow. We have to follow the contact precautions. We have to follow the respiratory precautions. So this has to be followed so that again there is not a cross contamination and further more spread of infection. Ventilator associated pneumonias and That is not only ventilator associated pneumonias, it's about CLABSI, it's about COTI, it's about VAP, it's about VAEs, and also patient falls. So these are things which we all need to understand, that these are the most common safety risks which can be taken care of. Safety strategies for this risk is following simple infection control practices like hand hygiene and the bundles that we need to follow. Medication reconciliation, I'm sure all of you are doing. The patient who was on medication comes with what was the list of medications the patient was on, so that you don't miss on a particular medication that the patient has been taking on for years, as well as you follow it and you have a review at it at the transition at every point, whether the patient has come from OT to ICU or ER to ICU, ICU to ward, and ward to discharge. At every point of time, this has to be followed. Use of checklists. Checklists help us in understanding whether we have completed the task or no, and ensures that we are not missing out on a particular thing which was one of the most important thing. And this also applies to our procedures that we need to do in the ICU, which is on the WHO surgical safety, because that is also equally important. In case you had to put in an ICD, the right side or the left side is equally very important for us to know. So these are things which are actually to be applied. And patient identification. Yes, most of the time, patient identification is not followed because people follow bed numbers rather than the names. And again, in names, there might be a patient who has the same surname. So we need to follow the patient identification protocols, because here it can be disastrous. Then comes accreditation, importance and standards. Why do we have these accreditations? Most of you must be in hospitals which are accredited with either a joint commission or a NABH or a ISO. Why is it important? It ensures the adherence to best practices. Accreditation is like you all going for an exam. It is like something which is on a continuous check. But you cannot do accreditation only at the time that we are going to have the audit. It needs to be done on a daily basis. It needs to be followed at the bedside. And somebody has to be there who is coming and checking on it, so that if we are missing on certain points, we know that this is missed and we need to follow it. So it ensures the adherence. Nowadays, patients also know what is JCI, they know what is NABH. And I'm sure in next few months, you will all know that there is this thing where every hospital should be NABH accredited, especially for the services which are related to the insurance services. I heard few days back, some of the patients for TPA process, when they apply or when they go for their insurances, most of them ask them to take particular companies, because there is a good coverage of the hospitals that they have with the best practices. So this is something which is very important, even if you build up your own hospital or if you're already in a hospital. And thirdly, it improves the clinical outcomes, because at the end of the day, whatever we do, it is all about improving the clinical outcome of the patient. So the two most commonest accreditations which are there happening in India, one is national, that is the National Accreditation Board for Hospitals and Healthcare Providers, and JCI, that is Joint Commission International. NABH is adapted from few of the standards of JCI, but it is more in sync with what we have to follow in our country. That is what it is about NABH. ICU accreditation in key standards, we need to understand about the patient safety goals. So first and foremost, I already told you, patient identification is very, very crucial, because it may happen that the patient's label, which is there, may be attached wrongly to the blood that was collected in Vacutainer. It may happen that the medication is wrongly labeled. It may happen that the blood transfusion is ordered wrongly for the wrong patient. It may happen that the blood group is not written rightly. So multiple things you need to understand. We have to follow the patient identification. Improve effective communication. This is one of the most important part in ICU. And for that, there has to be a strong handover. Unless we have a strong handover, the communication will not be good. So handover starts at multiple levels. It is within the department and it is with the other departments. So within the departments is also not only at the time of the shift, but also when you do certain changes at the bedside for the patient. You may go and do a ventilator setting change. You may go and change a vasopressor support dose. You may go and change an antibiotic. You may go and change a beta blocker dose. But all this has to be done where the nurse is aware of what you have done for the patient. Okay. Equally, you have to also have a good communication rapport with the other departments. It is with the dietitians, it is with the physiotherapists. Also, you need to have a communication rapport with even a radiology. If you're going to send a patient for a CT scan, you need to ensure that there's a proper communication and planning done for that patient who is going down. So all that is about effective communication. What time you have taken the appointment, whether you have checked everything, whether you see the risk level of the patient, you require some help from the anesthetist. All this is about the doing the safety practices. Then safe medication practices. I already discussed about it. We use lot of high risk medications in the ICU. As I told you, it is vasopressors, it is heparin, it is insulin, it is about, for our ECMO patients, we put them on drips. We also have the patients who receive insulin. Insulin is a very basic medication, but if it is not given in the right way and if it is not monitored, it can be catastrophic and there can be even hypoglycemia. And that hypoglycemia in the ICU actually is not acceptable. And then comes the narcotics. So narcotics are again, we have to do a proper monitoring. So you need to see to it that you follow the protocols which are set by the institute. Electrolyte correction, potassium, phosphorus, magnesium, calcium. These are the medications which you give frequently for correcting the electrolyte levels. But it is important on how you are writing your order for this. If you are writing a potassium correction, you need to write not only the dose, but the diluent, how much it is diluted in, how much is the rate it should go, and what are the targets that you need to set. Okay, and what is the duration which is most important. So these are certain things, and also whether it has to go central or peripheral. So these are certain things that you need to do. Then I told you about ensure the correct site, correct procedure, applicable in ICU also for the procedures that we do. I gave you one example about pneumothorax, where if you have to put in ICD, but you still need to follow the checklist which is there for the correct patient. And the checklist also says you to see the previous reports. So you're going to check on the platelet count, the PT-INR, certain things which are required before you do the procedure. Reduce the risk of healthcare associated infections. In ICUs, we may get a patient who is developing an infection or has already come with the infection from an outside hospital, who has come with outside tubes and wires. So this needs to be taken care of. We need to follow the isolation protocols. Do not mix the instruments from one room to other room. Do not take the step from one room to other room. Or if you're taking, see to it that you have cleaned it properly. Simple, follow hand hygiene. And hand hygiene, two things. It's not only about using the hand rub on our hands, but also following the 5 moments of hand hygiene. Most of the examiners, this slide is very important. You need to know this properly because they may simply ask you about hand hygiene. They may ask you about the, 5 moments of hand hygiene. Anybody can tell me the 5 moments of hand hygiene so it's not monotonous? Anyone? Any participant can say 5 moments of hand hygiene, please.
Guys, kindly respond 5 moments when you have to do the hand hygiene. Very basic question you would be asked.
This is the favorite.
Madam, may I answer?
Yes, please answer. Waiting for answer.
Before touching a patient,
Yes.
before touching any fluid related to the patient, before accessing the central catheters, central venous catheters, and after touching a patient, and any procedures.
Anyone wants to correct?
Before touching the patient surroundings and after touching the patient surroundings.
Yeah, so that is those. So this is the moment which is missed by most of us. Just try to retrospect and look at yourself. How many times you touch the hand rope before you go and change some syringe pump, you adjust the levels, or you go and touch the ventilator, or you go and touch the monitor, or when you're coming out of the room and you've touched a curtain. So these are few things, and these are the common things from where the infection is spread, actually speaking. So these are very important things that you all need to know, and this is a common question which is asked during the exam. And then comes reduce the risk of patient harm from falls. Yes, ICU patients are vulnerable patients, and it is not that in ICU there won't be falls. The patients they are more delirious. They are thinking some patients don't know this is not their home. They may try to come out of the bed. They may become aggressive. So these are certain things that we need to take care of. And then comes the clinical guidelines. Clinical guidelines is all about following the bundles of care, which also now we all know about the sepsis bundle, which is very important. And there are multiple aspects in sepsis bundles which can be monitored. ICU stopping norms is something which is asked all of them because it is involving a main part of the safety. So if it is a patient who is a patient on ventilator with multiple vasopressor support, you should be having ideally a 1:1 nursing. If a patient with the IBP and with a ventilator, 1:1. But if a patient has ECMO, then they will require 2 nurses and one patient, because there is a multiple things which happen to the patient, and also it can include the technicians and equipment calibration, because if your equipments are not calibrated, they will not work at the last minute. You all must be seeing in your ICUs how the nurses come and check the defibrillator daily at every shift. This is to ensure that in an emergency, the defibrillator is working. But sometimes you should also go and check so that you know how it is checked and what is done. This is the dashboard to make it easier for you all. This is what we have in our hospital. And this is an old percentage of benchmark which is there, but this is in sync with last year, which was put up for and we are following the ICCM guidelines. So you also know about the ICCM guidelines, where there is one of the articles which mentions on which are the ICU quality indicators which one needs to monitor. So simple, it starts with the bed utilization rate. So outcomes are, what are the outcomes that you have? So it is based on utilization rate, length of stay, rate of readmission, rate of intubation, calculation of SMR, pressure flow rate, hand hygiene compliance, ventilator associated event rate, then possible or probable VAP, then CLAPSI and COTI. And safety is all about accidental line removal, medication errors, patient falls, and multiple more. Okay. Process. I think someone is talking, sorry. About process, we'll come to the next, where we will tell you on how do you check on the processes, and that is about the clinical audit. So till here, any confusion? So if anybody has, you can ask me, because clinical audit is one part which will take a little more time. I hope you all have understood till here, and is it clear till here?
Yes, ma'am.
Are you getting the points which you will be able to answer for the exam?
Yes, ma'am. Yes, ma'am.
Okay. Then comes the clinical audit. So simple definition, you remember, it is very easy. A systematic review of clinical practices to improve patient care. Okay. Nothing but a review of what you're doing for your patient care, where we can improve. NICE has put up a definition that it is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria and implementation of the change. So what it is saying, the same thing, but you need to have the criteria. So what is the purpose? Purpose is to identify gaps in compliance, benchmark against the best practices, and drive continuous quality improvement. Believe me, you might think that you're doing everything as per the protocol that has been set by the hospital. But unless you deep dive into it, unless you go and do a check, you will realize that there are multiple points which are missed and multiple things which can be corrected. So clinical audit is one of the things which can be done to look which are the missing points and see where we can improve, or most important is understand what are the problems that are there because of which they are not done. So types of clinical audits in ICU is process audit, that is like compliance with sepsis protocols, VAP bundle adherence, CLAPSI bundle adherence, Outcome audits, I told you already, mortality rates, infections, readmissions. If you have readmissions, you need to go and check into those readmissions. Why was the patient admitted? Had the patient recovered completely? Was the discharge criteria at the time of shift out followed for that patient? And why did the patient come back? What could have been done to avoid the readmission? So these are few of the things which you need to look into. Structure audit is about the ICU staffing ratios, equipment availability, and equipment calibration also. Steps in conducting a clinical audit. First and foremost, that you need to select the topic. Now, how do you select the topic? The topic may be, see, you might say hand hygiene, but hand hygiene is normally done by infection control in most of the hospitals. There are surprise audits, somebody might tell you also. So it may not be only hand hygiene. This is just given an example. But you need to see on the problem area. What is important is you need to check what is your problem area in the hospital or in the ICU. It may be simple communication. It may be simple medication errors which you see. Even if one patient has had a very severe medication error, you need to go and look into the practices. So you select what is the practice that you need.
Is it just renal replacement?
So you need to look into that. I had done now recently for CowCon, actually, I have done a clinical audit. I have judged, I've seen at least some 18 clinical audits which were there, and people have done very nicely on the clinical audits. So there are multiple hospitals who are doing it, Hospitals have gone and checked whether the patients who underwent the angioplasties, did they really deserve the angioplasty? There are particular criteria which are put up. So set standards. For the standards, you need to refer to the guidelines, and which are the guidelines which are proper guidelines. It may be a WHO guideline, it may be a JCI guideline, it may be anything. Data collection, you need to see to it that you have a proper data collection put up. So what are the parameters that you need to put up? So therefore, what are the parameters that you need to be put up will be based on what is your clinical audit that you have put up. So when you put up the parameters, they have to be very specific. The parameters have to be measurable. They have to be attainable, that you go and check it. They have to be relevant to the topic, and they have to be time-based. So you cannot pick up something which you are supposed to do today or tomorrow or day after. Suppose if it is said that, just to give you an example, that if it is set for a clinical audit, that whether the patient's door to balloon time, how much it was. So door to balloon time is something which you all know for a MI. Nowadays, there are groups in hospitals where patients go for PAMI, and once the PAMI is done, the nurse from there will put down what is the timing, within how much time the door to balloon was achieved. So these are all very important which you need to check. Compare the results, benchmark against the standards, see if there are any problems, whether the problem is related to the process, whether the problem is related to a training which is needed, and then do it. And then you again go and re-audit. Because unless you go and re-audit, you will not understand whether the problem is solved or no, and whether it is in control or no. So I hope this clinical audit you all have understood. Examples can be simple VAP prevention bundle compliance. Maybe, finding is low adherence to head of bed elevation. So again, you will have to go and check the staff training, check whether the beds are well, properly, they are easily, the staff can use for elevation and putting down back, and see to it, those parameters are taken into consideration and those parameters are put up. And you need to also target every time. What will be your target? So suppose if there is something which is non-compliant, you say that I will improve the target by 30% or 40%. So basically, it is a quality improvement project that measures current practice against the agreed standards of best practice. The aim is to evaluate how close the practice is to the best practice, identifies the ways of improving the quality of healthcare provided, aim to improve services, and it is usually led by service providers. When I mean service providers, we all become the service providers. It has to be an ongoing process, and the collection of data is, it is just not related to your standards that you have for the JCI and NABH. This is simple JCI and NABH, the standards are what are the requirements for the certification, or what are the things that you need to follow. Clinical audit is something, whether it is following the 1 hour bundle of sepsis, whether it is following the antibiotic appropriateness, whether it is following, I told you, on the timelines for thrombolysis, whether it is on following the protocol for anticoagulation or electrolyte correction. So these are certain things. You might simply go and do a medication audit and see that for the potassium correction in the ICU, how many orders were put up which were properly put up. Even if you do that much, you will realize that there have been so many gaps. So these are the certain things that you need to do in a clinical audit. Challenges in ICU quality and safety, lot of resource constraints. We all are aware about it. There is a lot of turnover of staff, and that is the reason it becomes very, very difficult. Also, there is a change of technology which is happening. So we all need to be updated with the technology. We all need to be updated about it. Same way, resistance to change, adopting to the new protocols. Data accuracy is one of the problems, which is actually, it is all in our hands. Unless we document, we will not get these things easily to go and capture and to understand where are the gaps. And this is one of the things which is a common thing in the physicians, because we physicians always hesitate in completing the documentation. We tend to say, I'll do it later, I'll do it later. But that is not the way. You have to finish the documentation on time. You have to ensure that the staff gets to know what is the plan. Unless you document, the nurse will not know what is the plan. Everything cannot be on a verbal saying, Maine bola tha. It is about writing down and seeing to it that the staff gets a clear-cut instruction on what is to be followed, and compliance monitoring. Unless you go and check what you are doing, whether it is done rightly, what are the things which need to improve, we are not going to correct ourselves. So conclusion is, quality and safety are continuous processes. Accreditation ensures structured improvement. Clinical audits drive evidence-based changes, and collaboration amongst ICU teams is the key, which is actually speaking, most of the ICU teams, if they collaborate, we can come up with a lot of things. And in critical care, one of the best things is we have a lot of bodies. We have ISCCM, we have SNCC, we have a lot of team members who actually put up a lot of updates, who give us a lot of guidance on what we need to follow and why it is important. So conclusion, if it cannot be measured, it cannot be monitored. And if it cannot be monitored, it cannot be managed. So that is in short that I thought it is the most important part. Any questions? I'm ready to take now. I thought it's better to just put up the glimpse and then take the questions. Any questions? Arindam, have I covered everything?
Can you once again give a little bit of a quick review so that everyone gets a name? So we started with from the first slide, so that I can also give them a little overview.
Okay, you want to the slide? Okay.
Uh-huh.
I think I will.
Because I will play the part for the overall this guys. We'll go back to the first slide or second slide, maybe not the intro slide.
Intro.
So we now know the objective, right, of understanding this, and why we need this, because the safety standards and the safety and quality standards of ICU care is comparable to the aviation industry, because the margin of error is much less. That's how you have to be absolutely precise and aware. So that is an A. And the safety standards, Darshana, did we cover a little bit on the near miss events or something of that? No.
Sentinel event I have not covered.
Sentinel events, just
That's
give them an
not-
idea that whenever
Okay.
you have any bad thing happens, that called be sentinel events. So, and events can be divided, particularly events which causes actual harm. They are called sentinel events or harm events, and the events which actually didn't cause but could have caused, we call it that a near miss events, something of that sort. And there are a lot of safety trainings and standards that are also there, including the Six Sigma and all this. Let's go to the next slide. Quickly, we have understood the principles, right? May not be quickly asked, but these are all the different principles of the quality. Next, then we also discuss these are the components. One is that you have to have a good clinical excellence itself. Then the process of delivery efficiency, right? How you deliver your care, good clinical care, and how you deliver it, and how you center it along the patient, right? This term is used right, left, and center now. Patient-centered or patient-centric care, right? Everything is in relation to the patient and then their comfort, their dignity. You tell everything. You take their you respect their autonomy, you follow the process, you do whatever they ask and all others. So patient-centric care on that part. And whatever you do, you measure it, right? And publish it and make it accessible to other people. So that's called performance metrics itself. So these are your key components of the quality. Next, I think then we had discussed the safety, particularly uh, four component: infection control, medication management or reconciliation, right? All the checklists, right? You must have heard about the very famous book Checklist Manifesto. One of our Indian guy, Dr. Gawande, has written it. He is a guy who came up with a surgical checklist which has saved millions of lives, right? So bundles and checklist, know about it because these are certain uh, processes that has to be done. And always remember the rule of thumb of checklist and bundles is all or none. That in a bundle or in a checklist, you have to do everything. So 100% compliance has to be there with the components. Otherwise, it won't work itself, right? And next slide, where Darshana showed, I think the accreditation, right? There are two major accreditation. These are quasi-governmental board, NABH, right? Where they give you that this institution is following certain standards and and accreditation process certifies that the hospital is of certain levels and standards. It follows the processes and it is safe, and many of the your payer, that means the people who pay for your healthcare, be it your government, be it your schemes, governmental schemes or insurance or any other third party company and others, they look into the accreditation certifications for it. So that's the importance of every hospital for it, right? So major NABH and JCI, which is an international which is now, as of now, India and Southeast Asia, a little bit. That's an NA. So this is why the importance of accreditation. Obviously, the official is adherence to best practices, confidence, and clinical outcomes, but also in practicality, right? The certain tie-ups and better pay for the third party payers, as well as attracting more patients because of it enhances the patient confidence itself. Okay. Next one was, I think this is the IPSG goal, right? The 6A, communication, medication practice. This is a very common question asked in what are your 6 international patient safety goals, right? Darshana has covered it, right? So these are your identify the patient, good communication, medication practice, prevent infection, prevent fall, right? And other non-ICU is safe surgery, right? Identify the safe surgery itself. So, and these are other clinical guidelines itself. So it was covered. Then next is, I think she also discussed about the dashboard. Always remember most of this, these are one very common is your the concept of Donavedian concept of an ICU or any other hospital quality. is called the SPO concept, structure, process, and outcome. So for any, not only hospital, everywhere. So you first, if you want to measure the process or measure the overall effect of that, so you see whether how the good the structure is. That means in context of ICU is that how many beds, how many doctors, what is the ratio, doctors ratio, nursing ratio, and all others. So what is the infrastructure that you have provided for that? Then how you define the process, right? And lastly, what are the outcome metrics? That means what is the mortality, what is the morbidity, what are the other outcome related, say. So ICU dashboard tries to uh, cover mostly. So if you see the category, this is the outcome category. Mostly the outcome metrics are A, but also outcome metrics should be also corroborated with the structure related metrics too, right? So these are your LOS, which is very important. Utilization of bed, you can see. So the benchmark is 60, but any private institution always wants to have on a higher A. But remember that anything more than 80, 85 is sometimes can cause a difficulty in the process efficiency, because there will be very high turnover and then sort of bed clogging and all this happen. Length of stay LOS, we do have benchmark for different disease process, right? So obviously certain disease will have a higher length of stay. Remember that the denominators are always very important. Readmission is also important, because whether if you do it too early, then the patient will come back, you will have a higher. And if you hold on to your patients, you will always have a very low readmission rate. So that's why most of the hospitals give you a reference range. So for example, Darshana, how is ours? 2 to 4%, like that? Or 1 to
No,
2%?
no. So as per, sorry, here I forgot to tell, rate of readmission, ICCM has set a benchmark of 6% and reintubation is 12%. But we
Ah.
have been within 1%. So our target is brought down further so that we keep up to the best practices.
SMR is the most important one, right? Observed mortality by predicted mortality, right? It should be below 1. The benchmark is always below 1. So always remember that with your Apache scoring and other mortality scoring, right, there is also a predicted mortality. So that means if you combine these two, that this patient has a score of this and this is the predicted mortality, and at the end of the month, when you combine everyone's data and find out that your observed mortality is less than predicted mortality, so ratio would be always less than 1. That means your unit is doing a better job. So this is a very favorite question in exams on SMR itself. Rest all are already is self-explanatory, right? And you will have this in your this would be available, this video would be available, so you can very quickly look into it. But most of the Darshana, these benchmarks are given by whom? Is it given by NABH or any other?
No, this benchmarks are our ICCM benchmarks, Indian.
Okay. Now this is our societal. Now,
Yeah.
but who are the other organizations which can give benchmarks?
So other organizations is basically for every specialty there is a society. So what I mean to say is this is what it is. It is either a national or an international.
Okay.
So if it was international, so if we are going to say SCCM, SCCM is the main body which puts up mainly related to our admission criteria and all that. So they have, but ICCM has taken from different international bodies, looked at our internal bodies and then come up to the benchmark. So it is that way. They need to remember only about ICCM according to me. That quality paper which is there, if they read it well, they can answer it well for the exam. There's one paper which was of 2009, which has all the details, formulas and everything. You got my answer, Arindam?
Let's go to the next one.
This is the clinical
I think
audit.
audit you defined. We all know that because this is a, you also defined, next slide. that how to do the different types, process outcome. As I told you, Donabedian concept next. And then these are the steps, right? The smart one. And these are certain examples that how you have done on that part. And yeah, I'm fine. I think you very clearly, nothing to be discussed here. Next one,
Just the challenges that we face.
challenges, constant resistance and all others. Anything else next?
Nothing.
Huh.
This is the
Now,
last.
anything you want to cover on the safety, I think, if you say so.
Safety is what I told in many ways. Medication.
And
I
the
told
events mostly. You
medication.
just give them a little idea that how you do the medication management, then
So medication management, if we ask from a safety perspective, it has to start from the prescription. First and foremost is our orders. So unless we write the orders clearly, so there are two ways of doing the orders. One is either we are using the pen and paper where we are writing it physically, or it can be on the electronic system. So if it is an electronic system, the issue of capital letters and the numbers does not become a problem. But if it is pen and paper, then we need to follow the
block
simple.
letters. So you have anyone who is working in an NABH institution know that you have to write it in block letters. So there are no way. And also, is there now a mandate to write the pharmacological or the generic name?
The generic name that we have put up, and there are standards which are put up also by the respective medical councils also.
And also very clear route of administration and the frequency, and every A is to be signed and timed and dated, right? And the sign is legible signature with the, now everyone is asking for the stamp or the full name or something of that sort. So
And the
these are,
duration has to be mentioned. Duration of the
and
medication.
in digital, it's obviously you are logging in with your credentials, so the system will automatically take up that it's Darshana Rathod who has prescribed at certain date and certain time because she has to log in with her own credentials itself.
Also, it is important when it is coming to medication, two things. One of the things which most of the doctors miss is on writing on the route. So, like heparin can be given IV, it can be given subcut. So, this is something very important. Insulin can be given IV, it can be given subcutaneous. So, those routes are equally very important. That's very important part for writing any medication. And verbal orders, especially in ICU, there are a lot of verbal orders where we keep left, right, center. Lasix 10 mg they do, but whether it is IV, oral. So these are few examples. Beta log reduce kar do, but what is the rationale everyone needs to know? So these are few things which are very important from a patient care point of view. I know it's very difficult to do it and implement it, but it is very important also. So because anticoagulation, as I told you, anticoagulation.
I have one request to you. Can you give certain examples of the safety initiatives that we have taken?
So one of the things which I think in this only PPT I had put up is one, I don't know, because I had done one, we had this girl who was going to UK, and we had done one of the things which was about doing the medication, high risk medication audit. Can you see it, or shall I just again share?
No, you have not shared. No, I'm talking about not only that, any safety initiative like the color coding, right? Where you cannot
Color coding and this thing is there. Color coding is one of the
the
things.
color coding is in infection control, as well as if you see clear universal color coding everywhere. Then you have your different pins, different sockets for different tape, right? So these are all fail-safe measures where it is in different steps you are given warnings that you do not commit a mistake or you do not commit an error itself, right?
High risk
And
medications are red colored. Then medications with the this thing yellow colored are with the same name, look alike, sound alike. So all those different colors are used so that the nurses know if it's a red sticker, they need to double check it before they administer to the patient.
Then every infusion lines are also marked, right?
There
So
is a
that there are
label on
no
that,
jumbled
which
up.
medication is going through which line, so that there is no mixer of giving a vasopressor and IV fluid fast, basically, or a potassium and any other drug going on through that, or anticoagulation or any other drug going through that. And safety is not only about medication. Medication in ICU, it's many things. It's about also the connections that we have, the connections of the oxygen, the connections to the gases, the connections to the suctions. All those things are the most important aspects, because if you have patients who are with ICD connected to the suction, but one of the tube got disconnected, there can be a pneumothorax, there can be an emphysema. So we need to look into all of these parts. Or a Foley catheter, if it is pulled, then the patient will develop a hematuria. So these are few of the things which are very important, and therefore delirium becomes very important, because you don't want the patient to pull out the tubes and wires accidentally without understanding the importance.
Do they need to know a little bit about the different chapters of NABH, if you can give?
No, they don't ask about NABH chapters. They will just,
At least at the ICU?
no, they will ask, ICU, they will ask only admission criteria, discharge criteria, which are put up in all hospitals. Admission criteria is based on the objective criteria, that is.
Now, just how many? Seven chapters, right? If I'm not mistaken. And what they call the schedules?
No, that chapters are divided into governance and
Fifth edition.
leadership, continuity of care of patients, then multiple medication management, HI, hospital infection control. Then it is related to the management of information, that is MRD. Then it is related to the facility management. So these are a lot of chapters which are there. And when it comes to the codes, codes is something which all hospitals nowadays have: code blue, code red, code green, fire, emergency, ACLS. So those kind of things. The prescription, I think Vishal has been asking 2 questions. Can we ask about NABH criteria and all? You will not be asked about NABH criteria at all in this. What you will be asked is only about what I have
Even
told
most
you.
of the examiners won't know, but
So they will not ask you this. And
don't worry.
prescription about the restraining orders that you have put up, Vishal. The restraining order is because any restraint which is there, first and foremost, you don't try to put a physical restraint to the patient unless it is very mandated, where it can cause a harm to the patient or to someone else. And the order is important so that the nurse knows that you have also seen and you have seen the patient, and then you have given the order for the restraint, and the consent is taken for the same.
Now, in the this is the 5th edition ongoing, right? Of NABH, or 6th?
5th is ongoing now. The 6th will come now.
So 5th edition has 10 chapters, if I'm not mistaken.
Yeah, it has 10 chapters, but related to ICU are what we have put up in this PPT.
Now, if you are interested, just have a look into your Chapter 1 is access, assessment, and continuity of care. Chapter 2 is care of patients. I have the manual. Chapter 3 is
Access to
medication management, which is very important for ICU itself. Most of the things happen. Chapter 4 is patient rights and education, right? What the patient, what are the rights, what are they have to have the display and all others. Then your family counseling, and how they can have grievance, complaint, and everything, right? Their facility, privileges, billing, and all others. Chapter 5 is again very important for us, is infection control, right? HIC, hospital infection control. We all know. Chapter 6, patient safety and quality improvement process, right? Chapter 7 is responsibility of management, ROM, right? These are all your color coding, then what are the safety initiatives, what are the governance supports, who are responsible for the governance support and all others. Then organization discloses the donor ownership and everything and all that. So mostly the management related day. Then chapter 8 is facility management and related safety, right? This is all facility means you must have seen there are facility directors in hospital and others. So this is mostly the ancillary services like food, laundry, housekeeping, security, then transportation, then and others. So their utility, biomedical waste. These are all your people in their facility. Did I miss anything?
No.
Engineering, I missed it. Electricals and engineering. So these are your
Engineering is with
facility.
the facility.
Where is the fire management comes into this one, right? Facility.
All facility. It has everything.
So facility management and safety, fire management comes. Chapter
Everything.
9 is your HR, how you handle your human resource, how you get the best out of it. There is a concept of ergonomics into it, right? That means how you can design and get the best outcome from your resource itself. There is also a concept of implementation science, which is included both into the this facility everywhere, in fact, but mostly in human resource management and the new which has been added in this 5th edition is the last chapter. I think it wasn't there in before. If I'm correct me if I'm wrong, is information management system, right? The IT because so here again what are your needed mostly the processes for data collection, how you analyze, who can do the entry, how it is signed, how you can prevent the data from leaking or from tampering, then who can share, with whom it can be shared, what are the process for document and control, right? How you keep the records of your active and patient who are discharged, right? Both in sort of a. So these are your the total 10 chapters of a, right? First one, assessment, the care of patient. Third is medication management. Then you have patient related A. Then you have infection control, patient safety and quality, facility management, HR, and information management system, right? So these are all your things. Late. I think anything I'm missing?
They only need to know about the PPEs. You all need to know how to wear your PPEs, especially if your patient is in contact isolation or if you have a transplant patient or if you have a patient who is in isolation, then what are the practices? That all is something because infection control is the most common thing which everyone should know.
Couple of important day that World Patient Safety Day. We know World Health Day, 7th of April. World Patient Safety Day is 17th September itself. These are
And hygiene day will be on May 5th. May 5th or 6th.
And certain sites where you can is Toristua and others. Okay, so any other questions? I hope it was helpful.
Sir,
yes.
Sir, Rohan here.
Okay.
Sir, but will we get a question on root cause analysis? Because they generally tend to ask every time.
A root cause analysis, the Darshana can ask. Ron, thank you. In fact, we do a
root cause analysis. You're saying in theory or in practical?
No, practical. They can ask RCA that it
RCA is something which is after a. See, remember one thing. There are two things to it. One is RCA. RCA is done after there is an event which has occurred. When I'm saying after an event that has occurred, if you just take a simple example of a medication error, okay? So if there is a medication error which has happened, then you need to go into a root cause analysis of it. So root cause analysis will be done where everything will be checked for that patient. It will start from who has prescribed the medicine, how much was depending on the type of error. So suppose if a patient has received a wrong medication, so then there will be an entire thing done from the time the patient entered to the hospital, and then there will be every check done, medication reconciliation done, whether there was a check by the physicians at every shift, whether there was a continuation, discontinuation marked at the time of review, and then after the medication, whether it was given, what were the side effects, what could have prevented, the 2-point checks. So everything can be done. So based on the incident, there will be a root cause analysis which will be required. Or if it is a CLABSI, even sometimes we do root cause analysis for infections also. So we tend to check into multiple things, whether the line insertion was done properly, was the line needed, how was the maintenance bundle checked, whether there was an insertion bundle which was checked, everything. Rohan, you got it?
Rohan
Okay,
also
ma'am.
wanted to ask about the CAPA, I think, corrective action and preventive
So based
action.
on the observations, you come with a corrective and a preventive action. Corrective is the immediate action. Just take a simple blood transfusion reaction. Suppose if you have a blood transfusion reaction, what is the first thing that you do, Rohan?
We stop the blood transfusion, ma'am.
So you stop the blood transfusion. So that is
And
the
then
corrective
we inform the blood bank.
We inform blood bank, we stop the transfusion reaction, we collect the blood and the urine for hemolysis. We
For
send the
hemolysis related
back to the blood bank. We give the patient hydrocortisone evil. In case there is a suspicion of hemolysis, we start the patient on IV fluids so that the hemolysis is cleared, and we keep a continuous check. If then you need to divide it into reaction, whether it is a trolley or whether it is a taco also. So you need to look into that. Depending on that, you might have to give the diuretics, you might have to give the nebulizations, you might have to give the NIV. So all these are the corrective actions that you're doing.
Now also you have to document, you have to inform other authorities,
the
you have to talk
transfusion
to the
form that
family
you will
members,
see.
everything comes into it. And
Yeah.
preventive action is that for other patients, what you do to prevent any similar occurrence. So this CAPA is applicable in any of the events, medical errors, events, or anything that had happened. So one is how to deal with this particular incidents, this particular patient, how you can minimize injury or minimize harm to the patient, and preventive action, how you can minimize occurrence of such events in future. So that's an NNA. Okay, so this is very commonly asked in
Yes. Yes, sir.
exams. Regarding Dr. Vishal, IJCCM, you can just say, not only IJCCM, there are loads of very good articles. We are coming up with the quality guidelines for ICU, but as of now, ICU standards had been published by Dr. Rungta and Dr. A. That gives a basic outline of this SPO from the array. Darshana, do you have that article from ISCCM? Can you please share in the group whenever you get time?
I'll do it.
We'll share in the group itself. You can have a read on that.
I'll do it.
Any questions?
That article has the benchmarks and the formulas both.
One is benchmark and one is that your standards and ICU standards sort of they have done it way back.
Sir, Rohan here again. Sir, do we need to remember the benchmarks for the exams as well? That
No.
occurrence of CLABSI, VAP. No,
SMR you need to know.
SMR is 1, ma'am. Yes, that we know.
Less
but
than 1?
Apart from that, yes, less than 1.
Others you don't need to remember the benchmark. You just need to know how it is captured or what is it. I don't think people ask you that. What I know is they ask about SMR.
Okay, ma'am. Okay.
At least you give a range rather than exact A. Some fair idea of that A.
Okay, sir.
So should we read any other landmark trials from IGCCM for our exam?
I answered you on this.
other than these ICU criteria and ICU standards, means any other articles that are landmark in last 3-4 years?
Darshana, do you want to comment anything? Now, why only restrict to IJCCM? Right, I'm not sure whether IJCCM has come up with many landmarks related to the quality itself, but we will share certain articles in the group itself. We don't have
Other than
by
sir, quality, I mean, other than
quality related articles are none. You are
No,
talking
he's
about
saying
quality
other
or
than quality. He's saying other than quality, Arindam.
other than quality? I will try to compile, boss. As of now, very landmark or practice changing papers, I don't remember something has come up.
Sir, Rohan here. Sir, we
Bola.
have that PPT or a PDF of that 50 or 60 landmark papers that you shared just before theory exams. I think that might be helpful.
दोबारा शेयर करना ग्रुप में
करता हूँ सर, करता हूँ.
वो पढ़ के जाओ विशाल जी, उसमें ही आ जाएगा.
Yes sir, वो तो है, but regarding IJCCM only, because there are few.
मैं देखता हूँ जे कोशिश कर.
We can ask from, as we are going. There are some of.
I will try to give you in couple of days time. It's a good idea. I would write and I will try to have a collection of articles which have the highest citation and others in last 5 years. That's how you actually highest downloads and highest citations. That's how you sort of determine which has the biggest impact. Let me find out.
Yes, sir. Thank you, sir.
Sir, please elaborate a little about the fire safety protocols and the standards that we need to follow.
Darshana.
Fire safety in ICU, it is very important because we need to have a protocol which is put up by the hospital based on the infrastructure that we have. Nowadays, most of the new hospitals have the fire doors, but the old hospitals may not be having it. So the fire doors are the doors through which the fire cannot cross ahead. And then we have the fire exits which are there. So every hospital, the people who are working on duty, first and foremost need to know that there is at every central station, there is a bar which you can see, which is where you can see the main oxygen, how you can stop the main oxygen, main gas, as well as the gas supply. So there you can see that how you should know how to use it. Every engineering team will come and tell you. The second thing that everyone needs to do is that everyone needs to keep in the ICU on a daily basis, especially the nursing, they have to have a list of the number of patients who are on ventilator, number of patients who are on supports like the vasopressors, or number of patients who are able to walk when they have to be taken out of the ICU. If there is a sudden fire where you need to actually.
So we have an updated board actually,
so
where it is displayed.
So every shift the nurses should have.
Every shift we update it.
So every shift your numbers should be total. Plus they should have, if you have the number of staff as well as the number of relatives, if there is a relative waiting area, and including the security and the PCA and the PTA. Then comes this, that in case there is a fire, same way like what we do, we need to see to it that what is the action taken of disconnection and everything. The reason we need to know the number of ventilators, the patients that we have, we need to have that many oxygen cylinders properly placed, because there can be a central supply which will be stopped in case if it is required, and they will be announced on the system. And you need to ensure that your patient has the back mask and the oxygen cylinder at the bedside to see to it that the patient is not deprived of oxygen or ventilation. And then there are drills which happen. So there are two ways of evacuating the ICU. It may be either a vertical transfer or it may be a horizontal. So if on the same floor, if you have two ICUs, then the other ICU which is there where the fire is there, you need to put down which are the people who can walk down. The second who can be just put on with the help of a relative or on a wheelchair and still be sent to the evacuation area or to the area which has been designated by the hospital. And the patients who are on dependent and are at very high risk, to whether they can be shifted parallelly in the other ICU on the same floor through the fire exit. And even hospitals nowadays have evacuation chairs and multiple gadgets which are there where there is a practice which is done. And if it is a horizontal, then every hospital nowadays has designated lifts which are for evacuation, which the lift can be working for evacuation. Or else, if no lifts, then there has to be a drill where how we will take this patient with a bag mask and unbuoying the patient with the oxygen cylinder and how many people will be required. So these are few things which at the hospital will. So you need to remember about few things which are like horizontal transfer, vertical transfer, which is the fire exit, and how to group the patients into different categories. Hope I've answered your question.
Ma'am, do we have any like guideline or any paper from where we should study up the guidelines regarding fire safety protocols in ICU or any standard?
So this is all, see, I don't know.
The fire standards are in your NABH. You just can talk to your quality person, right? And they will give you that what are your standards. Very quickly, 5 minutes, they will happy that a clinician has come forward to learn about fire, right? They will to take you a tour, look into the different where your extinguishers are there. What is the concept of fire door? What is the exit plan when if there is any unfortunate incident of fire? What are the signages? How frequently they do the drill? What are the carriages? How you can take a patient who is immobilized, right? And what are the the registers that are maintained, that how frequently they have done the drills, how frequently they have checked all the say. So these are your A. So these 4-5 points, if you tell, your examiner would be more than happy and give you full marks. Don't worry. People can't even spell out a basic A of A when we ask them these questions.
Sir, anything we need to know about design of ICU? Do they ask about that?
Yes, ICU design, ergonomics are very important. Darshana, you want to comment? Then I will add.
So ICU design or ergonomics nowadays, it is all about making it into a safety. Okay, and try to see to it that the patient, so safety factors, one is about each cubicle, how much is the size it should be, whether it should have so mostly most of the ICUs may not be into a cubicle pattern, but cubicle pattern helps in many ways because it helps in infection prevention, it helps in contact isolation very easily, then it helps in noise reduction, then it also has to have an infrastructure, the purpose of handling about whether there is a basin for using the hand hygiene practices which are at the bedside, the connectivities, the panels which are there to avoid disturbance to the patient, whether it is wall mounted or whether there are those panels which are there, the number of, we also nowadays ensure that each cubicle or each patient bedside has 2 oxygen ports which are there, because nowadays we always have patients who are also put on ECMO and multiple supports which they require. And then also it is about having the ICUs with the window where it is there is exposure to the daylight, and this helps in actually reducing the incidences of delirium. These are the main things, and then it may be that depending on the number of beds which have to be planned for the hospital, if it's a new hospital.
One is the ratio, right? So which is close to around 20, anywhere between I think 20 to 30% now.
Initially, it used to be 20%, but we all are understanding that now the requirement is going up. So now they are going up to almost 30% also. 30% is what they are doing nowadays. That's in the hospital.
If I summarize, it's around the numbers. Then your first is layout, whether it's a cubicle based or an open bay based, right, and all others, depending upon the numbers that you need. The numbers ideally should not be less than 8, because then it becomes financially non-tenable, and not more than 15, 14, 15. Then it becomes very difficult to manage. So in one unit itself. And then you have different on that engineering and electrical things, right? As she's told, mostly the gases.
Dialysis facilities.
Fire safety.
Isolation, positive and negative pressure rooms.
So all this say. Now, then engineering is your isolation, then your fire, then your electrical, your gas supply, your bed space, and all others, right? As she told that, for example, you have to have two oxygen port and two vacuum port, right? Many of the times, and one medical air. Because if one suctioning vacuum is not working, you can fall back on the others. Today, we started with 8 electrical ports, 7, 8. Today, even 14, 15 are falling short. And out of that, minimum 30% has to be UPS, right? So that there are uninterrupted electrical supply on that part. Then lighting and all this noise reduction, access and all stuff that's there. Then the design also includes facility, mostly the uh, uh, what we call the sluice, wet sluice, dry sluice, laundry, then functioning, then location of the facilities, seating arrangement and all others, then data collection part and everything, how it goes. Then also we need to look up on the, as she said, the fire safety, evacuation safety, and all this process has to be. Then the movement part, and then the location of the ICU itself. So it should be nearer to the, not very far from the regular services that ICU avail, particularly the radiology, the OT and all stuff. So that also many of the times the ICUs are located in the lower floors. It is not wise to put ICU in the higher floors, right? Because of the evacuation part and all others. Many of the cities have actually put a bar on even that you cannot have hospitals more than 7 floor, 8 floors. ICUs has to be on certain floors. So these are just keep these certain points in mind. I don't think you would be asked more than this.
It won't be asked. Infrastructure and all will not be
No,
asked.
they can ask. He's right. Infrastructure can be asked. There is one ICU design related in ISCCM guideline itself. You can read that. There we have even specified the space, bare minimum space, right? In NABH, we have bed space of, I think, 750 square feet, right? Minimum one bed, 720. 720 square feet is the minimum bed space for any bed. And ICU it's around 800, not very specified on that, but anywhere between 800 square feet is no. ICU we do not have a. I will put it in the group. 720 square feet is the overall bed say, but it includes everything. So just like because 720 is a big space, right? It's not only the big space, the space for the bed. So if you have a 10,000 square feet total or 1 lakh square feet total hospital space itself, you have to divide it by 722 to get the number of beds, right? That is the higher maximum number of beds that you can have, because bed space will include the other utility areas like lab, the diagnostics, your OPDs, your facility and all others. So all inclusive, that's how you calculate on that. Anything else? Okay, all the best. Carry on, and best of luck for the mock. We'll meet you in the debriefing, final debriefing sessions. And anything and everything you put it in the group, we'll try to get the service for your orders. Thank you.
Thank you,
Thank
sir.
you, Darshana, once again.
Thank you, sir.
For a lovely class. Thank you.